Oh, our friend Chuck, poor guy. So he did have a heart attack, and what they wound up doing with him was they wound up taking him to surgery, and he had a 3-vessel bypass. Let's see. It's been a couple of weeks now, and now he's in this cardiac rehab 3 times a day. During his, or sorry, 3 times a week. So during like his 4th visit to rehab, we've got him on the cardiac monitor, and he begins to say that, my heart feels kind of funny. It doesn't really hurt. It's just kind of beating kind of weird. He's developed an arrhythmia. And I'll be honest with you, so a lot of our patients that have a heart attack go on to develop arrhythmias. And one of the reasons why this happens is because of scar tissue. So whenever we go and we go in there and we re-vessel things, there's going to be some scar tissue in there, and that may affect the way that the conduction system works in the heart. I will say that we have less patients now who go on to develop arrhythmias after a CABG, because whenever we go in and we do the actual procedure where we're opening their chest and we're revascularizing them, one of the things that happens is that they do a couple of extra procedures called the maze procedure, and that maze procedure really helps to prevent and decrease the amount of patients who go into an abnormal rhythm. But we're in a learning environment, so we're going to pretend that he does have an abnormal rhythm today. So we're going to learn all about our anti-dysrhythmics medicines that are going to help us to decrease the amount of electrical activity in the heart and make it much, much better for Mr. Chuck so that he can feel his absolute best. These come in a couple of different flavors. Here's all of them kind of listed on one little cute little slide. They come in 4 different flavors, and we're going to hit the sodium channel blockers first. So with the sodium channel blockers, these are the medications that we use to act really, really fast. This is whenever a patient is really sick and needs something to be done right now, or else they're going to die. Remember, with electrolytes, with the sodium, the potassium, the magnesium, the phosphorus, all those drugs, when they're going in and out of their sodium channels, and also calcium, any of those medications help us to cause an electrical reaction. Those electrical reactions cause a conduction reaction, which then causes the contraction, okay? So these medications are going to help to kind of slow that sodium channel from acting quite as fast, and by that, the end result is a decreased heart rate. So again, we have 3 different types, 3 different sizes. These are good for both ventricular and atrial arrhythmias. This is a EKG slide that shows you a ventricular tachycardia. This is the kind of rhythm that, like, if it goes on long enough, it'll kill you, okay? So for these patients who have a very irritated conduction system, we want to make sure that we're treating them fast, so we're going to use one of these fast medications. Lidocaine is an oldie but goodie. Now, we've kind of talked about lidocaine previously when we talked about medications that we use to help to like suture and stuff. This medication is known as both an anti-dysrhythmic and a local anesthetic. So if I give it in the IV, I get that anti-dysrhythmic quality. If I just give it locally, I get the numbing quality, okay? We give this one IV. It's typically very, very, very fast to onset. We would see us giving this medication in those acute care units in the hospital. Beta blockers. Love our beta blockers. They're running and they're low and they come in and make you go slow. So we talked about beta blockers before, and with the beta blockers, what they do is they help to control the heart rate and make it go low and slow, okay? And we've talked about that previously, so you can go back and review that one. The other class of medications that we need to put a little attention to is our class 3 prolonged repolarization. That's a fancy word that basically means that it keeps the sodium from coming in and out of the cell quite so fast. Our prototype here would be amiodarone. We see this one a lot used with ventricular arrhythmias and also atrial arrhythmias. So someone who has like uncontrolled atrial fibrillation that we can't get under control with anything else, we'll try amiodarone. Amiodarone is also enjoying a very distinguished honor, and then a lot of times now you'll actually see that people utilizing this medication in our advanced cardiac life support, also known as ACLS, for whenever patients have their hearts have stopped. Here's a little drug profile all about amiodarone. For this medication, when we start giving it PO, it really takes it a couple of weeks to build up to therapeutic levels. The problem with that is that we want it to work today. The other issue is that if it takes that long to get there, it's going to take that long to go away too. So it has a really extremely long half-life. We need to educate our patients that if they develop what sounds like pneumonia after taking this medication, we need to know, because sometimes this medication can actually cause acute respiratory distress syndrome, also known as ARDS. The patient looks like they got pneumonia, they act like they got pneumonia, but their white blood count will be completely normal. That's just weird. And it can be a reaction to the medication, and it's an emergent reaction, not something that we would want to be like, okay, just come to the doctor's office, we'll give you one. No, this we've got to take care of now, or else we're going to lose that patient. Here's a fun little slide all about amiodarone. Our calcium channel blockers, we've learned about these. The most popular one to help to control arrhythmias, and the one that we see frequently in our town, is going to be diltalazem, also known as cardizem. Typically, whenever a patient comes in atrial fibrillation, we'll give them a loading dose of this medication, and then after that, we put them on a drip. Typically somewhere between 5, like starting off at 5 milligrams an hour, and that's usually about as high as you have to go. I have seen as high as 10, but 5 milligrams is usually our range. Other antidysrhythmics that are listed on here, we're going to talk about digoxin in here in just a second. I will tell you that adenosine is probably one of my favorite antidysrhythmics to give. When a patient comes in and they are in premature ventricular tachycardia and their heart rate's like in the 200s, we'll give the Denacard. The way that you do that is we put it in an IV that's really close to the heart. So I have a big honking vein right here. They'd start my IV right here, and they'd push that Denacard, and you're going to push it like this, like whoop, like it needs to go in like less than 2 seconds, okay? So you push the Denacard, flush the line, and then the patient's going to be like, oh my gosh, and all of a sudden they're going to go flat line, and then their hearts will restart in a normal rhythm, okay? That's what happens with the Denacard. We never do a Denacard by ourselves. We always have our team there. It takes about 35 seconds to do the whole thing, but it takes us about 25 minutes of preparation to get there so that we can give this medication. Denacard's a lot of fun to give. Again, my physician is standing right there with me when I do it, and I have that patient on a continual EKG strip so we can see the fast lines, and then you'll see it go flat, and then you'll see that patient will come back repolarize with a normal rhythm. It's kind of like chemically shocking the heart. So our cardiac glycosides. You have to know these medications because, once again, this is a nursing school favorite. If you ask me about a medication that they're going to pick on you about, this is one of the ones. You just need to know it better forwards and backwards. They like to drill this one into you. Honestly, I probably don't see as much dig today as I did when I first started nursing 20 years ago. So we have some bigger, better drugs that work a little bit better, but we can give our cardiac glycosides in order to help make the heart function better, and to help to control rate and rhythm. Digitalis. It's a magical thing. It actually comes from a plant. Okay. So it is classified as an antiarrhythmic. We will see it used here. We also see it used in patients with heart failure, which we'll talk about shortly, and then to treat atrial fibrillation and flutter. Like I said, there's been a lot of medications that are just a lot more popular now than our cardiac glycosides to help control atrial fib and atrial flutter, amiodarone being one of them. But I wanted to bring it up because, like I said, it tends to be a nursing school favorite. When we talk about cardiac glycosides, specifically about our medication, which its name is digoxin, it has 4 effects on the heart. It increases your heart contraction, it slows the heart rate down, slows the conduction of the heart cells, and then it increases your stroke volume. So these positive inotropic and chronotropic effects are what they're going to want to know from you. So our prototype medication is lanoxin, also known as digoxin. It does have a therapeutic level that we can actually measure, which is great. When we give this medication, before we give it, we always have to make sure that our heart rate is greater than 60 to proceed. If that patient's heart rate's not greater than 60, you don't get to give the medication. Not the PO version, not the IV version, you don't give it, okay? The other thing is that digoxin is really, really persnickety about its potassium levels. It wants the potassium not to be too high, not to be too low. It wants it to be just right. That's right. It's a Goldilocks drug. It likes things just the way they're supposed to be. Okay, ditch toxicity. So when I was in nursing school, this nurse comes to our school and she tells us all this story about this lady named Izzy. And her name is Izzy Digi. And I remember the story so well that I wrote it down and then I share it with my students today. If you'll remember the story, it'll help you to remember all of these signs and symptoms of this patient that's got ditch toxicity. But I'm going to read it to you, okay? So sit back, it's story time. Izzy Digi. Just pretend, okay? You were assigned as Digi, and when you go in to see her this morning, she complains that she really had a horrible night and just felt awful. That's malaise. In fact, her head hurt, headache, all night long, and butterflies in her chest just kept jumping around. That's that premature ventricular contraction. She tried to sit up and read her Bible, but the words were fuzzy and kept moving, the blurred vision and the delirium. She kept getting up to go to the bathroom because her bowels, that's a diarrhea, wouldn't quit moving. Later that morning, as you deliver her breakfast, she reports that she really isn't that hungry. Anorexia. And as you turn to leave the room, she vomits all over her breakfast tray. You're cleaning her up and she tells you that you truly look like an angel with those lights around your head like that, halos around the objects. So again, I hope that kind of helps you to remember all about Izzy Digi. Will help you to remember the signs and symptoms of ditch toxicity. I'm telling you, this is a nursing school favorite. They'll ask you about it. The good news is if a patient has ditch toxicity, we do have an antidote for that. The antidote is known as DigiBind, which is helpful. I like it whenever the antidote and the name kind of like mix in together. Okay, Mr. Chuck. So we get Mr. Chuck back into a regular rhythm and we send him home. But he calls and he says, you know what? I don't feel very good. He calls the clinic today and tells you that his stomach and his legs are very swollen. He can't even get his shoes on. You ask him if he's had any trouble breathing and he says, why, yes, especially when he lays down flat. In fact, for the last few nights, he's been sleeping in the recliner. You recommend Chuck come to see him. Based upon the symptoms we've discussed, Chuck has developed what? Heart failure. Okay, this is kind of the end result of a long-term issues with different cardiac issues. We tend to see heart failure in the later part of life versus the older part versus the newer part. So with congestive heart failure, we have a couple of different treatment options that we want to talk to Mr. Chuck about. But before we do that, we need to kind of understand which type of heart failure we're dealing with. So left side heart failure is more like the left ventricular side is starting to fail, versus the right side, which means it's more of like the right ventricle starting to fail. So when we talk to our patients about heart failure, we also go a little bit further and not just classifying as left or right, but we want to know how much this is affecting their daily lives. So a patient who has just marked limitations during, they just have limitations during just physical activity would be like a level 3, versus someone who can't even do any physical activity and they're always having symptoms at rest. Those are the worst ones to have. With our patients, we do have a very specific treatment regimen that has been tried and true and it works. The cool thing is, guys, you already know about all these drugs. You know about ACE inhibitors. You know about diuretics. I taught you about cardiac glycosides, beta blockers, vasodilators. The only other one that we need to add to our repertoire at this point is the phosphodiesterase inhibitors. I wanted to show you this brief little packet of information. This is kind of an old diagram, but what I really like about it is it kind of tells you that depending upon the patient's stage, if they're stage 1, 2, 3, 4, it kind of lines out the regimen that you would most likely expect to see that patient on. So with the phosphodiesterase inhibitor, sorry, I can't talk anymore. These medications help to, they're emergent medications. They work really well. They're IV, they're very expensive. And we will see a turnaround in this patient's congestive heart failure within about 15 minutes of administering the medication. The problem is it is just IV. For as long as the IV lasts, that's how long the heart failure would be turned around. So we have to use other therapies, whether it's ACE inhibitors, beta blockers, cardiac glycosides, to get this heart kind of tweaked back up so that this patient can go back home again. Otherwise, when we take them off the medication, they're going to decompensate and death might be possible. Okay, so what do you think Chuck's med box would look like today? It's a pretty good question, huh? Based upon all the things that we talked about Chuck, if we were to take out his little med box, what should be in there? What shouldn't be in there? So what we're going to do is we're going to have a little opportunity, a little points opportunity for you guys to take the information that you've learned about all these different medication classes, from the lipids to the high blood pressures to the diuretics, and if we were to encounter Chuck today, what should be in the box to keep Chuck healthy? So you guys use your information and do the best job you can. All right, guys, we are totally done with the cardiovascular system. Thank you guys for joining in, and I'll see you next time.